Hello, everyone. Welcome back to Karan Academy. My name is Karan. I hope you're all doing super well. Today, we're going to be talking about cancers of the renal tract, as well as the urinary tract, and touching base slightly on the various genetic and inflammatory conditions often affecting the kidneys. Now, this is quite high yield for your pathology exams, but I've still included a bit of extra detail just for this lecture, although it's not something that you would be expected to know from a clinical perspective. So starting off with the renal cancers, a few important types you need to know, and this comes up very commonly on pathology, but also from a clinical skill perspective, you need to know, I guess, the prominent features of each one, how they usually present and how we usually treat them. So in terms of renal cell tumors themselves, three main ones you need to know are the clear cell cancers, the papillary, and the chromophobe cancers. You then also have oncocytomas, which we'll talk about. Apart from that, we also have a certain tumor type called nephroblastoma that's very commonly seen in children, and as well as some other conditions like angiomyolipomas, as well as metastatic spread. And we'll touch base on all of these throughout this lecture. So when we talk about cancers of the renal tract, firstly, what are some important risk factors? Smoking is a very, very big risk factor for renal cancers in particular, although a bit slightly counterintuitive. It doesn't really make sense as to why, but important to know. Obesity, as well as radiation. Now, when we talk about radiation, this typically is either occupational or very commonly from the treatment of some other intra-abdominal cancers. This can be bowel cancer, prostate, ovarian, even lung. When we treat those cancers or as part of their follow-up where we expose them to high levels of radiation, you can obviously have neoplastic changes in the renal cells. Some inherited genetic conditions like von Hippel-Lindau syndrome and birdhog dupe syndrome are also linked with certain cancers. In terms of how they present, this is really, really important to know. Renal cancers present with a classic triad of flank pain, a palpable mass when you blot the kidneys, and hematuria. However, all three of them are only seen in about 10% of cases. So if you see one or two of these features, always try to rule out renal cancers, because seeing all three is quite a rare incidence. They're often picked up incidentally, mostly on imaging of the abdomen or the renal tract is when we might see a mass. And I personally know of a few people who have had renal cell cancer picked up because they were undergoing imaging for some prostatic issues or some bowel issues, and then they just saw a large mass on the kidneys themselves. In terms of systemic features that you need to be aware of, so fever, malaise, very common, typical of many cancers because of that increased metabolic demand. Polycythemia is an interesting one. So you have higher levels of hemoglobin. This is because of EPO. Now, EPO or erythropoietin is produced by your kidneys. When you have neoplastic changes in certain renal cells, you can have changes to cells that produce that erythropoietin, and therefore you can have very high levels of EPO, which is kind of your doping, right? When people dope in certain sports, very commonly they might inject erythropoietin to increase their hemoglobin and red blood cell count. So this is kind of similar to what's going on there. And as you know, the kidneys have a key role in blood pressure regulation. So you may often see hypertension as well. Now, it's important to know that the hypertension you see is often hormonal and not to do with the actual blood supply. What I mean by this is when we talk about the renin, angiotensin, aldosterone system, you know that the kidneys produce renin, and renin acts on the adrenal gland to produce aldosterone. Again, based on the very same principle of why you get polycythemia with the EPO, you can get hypertension because of the renin. In saying that, kidney damage itself is not a very common presentation of renal cell tumors. If you do a UEC or measure their eGFR, they might often have a normal eGFR. That's important to know as well. And you can have distal mets at presentation. So 25% of renal cell cancers present with distal mets. And the two important ones you need to know are mets to the lungs and to the bones, especially the vertebral column. So let's start off with from a pathology perspective, the different kinds of the renal cell carcinomas, and talking about a few differences between them. So starting off with clear cells are the most common type of renal cell carcinomas, or RCCs. They're mostly sporadic, and they often almost always have a deletion in the VHL, which stands for von Hippel-Lindau gene. In terms of macroscopic features or how it looks on specimens, it typically is unilateral and involves the pole. What I mean by pole is kind of the upper and lower ends of the kidneys. So as you can see here, you have a clear cell carcinoma affecting the lower pole. You can see some dark areas of hemorrhage. You can see a yellow solid fibrotic component, and you can see that it's kind of circumscribed. The margins are usually within the renal capsule, which is reassuring in most cases. So it typically is confined in the renal capsule. And in terms of microscopic features, you see a whole bunch of growth patterns from trabecular to tubular. So the normal architecture of the kidney, you have your tubules, your glomeruli, as well as trabecular structures. This is basically a disorganized version of that. So instead of having nice organized tubules and glomeruli, you have a chaotic growth pattern of tubular and trabecular both. Of the three, it has the worst prognosis. Most cancers you'd see, the trend you see is that the most common type usually has the best prognosis and the rarest type has the worst prognosis. RCCs are the complete opposite of that. So the commonest type is a clear cell carcinoma that has the worst prognosis. The rarest type, the chromophobe type, has the best prognosis. Next, we have papillary cancers. Now, papillary cancers are usually a cortical mass. So you have medullary and cortical tissue. This typically presents in the cortex. Necrosis and hemorrhage is very common, and it's more likely to be bilateral than other RCCs. As I mentioned, clear cell cancers are typically unilateral, while papillary tend to be bilateral. Some microscopic features that are important to know for exams include foamy histiocytes and smoma bodies. And it has a middle tier prognosis. So it's not the best, not the worst. Then we have chromophobe renal cell carcinomas. Now, these are the rarest type. They're about 5% of all RCCs, mostly sporadic, and they're usually derived from cells that make up the collecting ducts. And this has the best prognosis. So really good prognosis. I know it looks very scary, but it has a really good prognosis. So the cells have large choliocytic nuclei with wrinkled nuclear membranes. I don't think it's relevant to know how that fits in with the wider realm of things. But again, from a pathology perspective, maybe good to know. Then we have oncocytomas. Now, oncocytomas are a tumor, but they're not a cancer. So they're benign lesions. They're mostly sporadic, and they're associated with birdhog dupe syndrome in some cases. As mentioned, they are well circumscribed, but they're not encapsulated. What this means is that they are regular and circular, but they aren't bound by a membrane in most cases. And they typically present with a large central scar. And that's the buzzword you'll see for oncocytomas, where you have that central large stellate scar. In terms of microscopic features, they have abundant eosinophilic cytoplasms. Now, an important concept that we have to touch base on when we talk about RCCs is sarcomatoid differentiation. Now, what is sarcomatoid differentiation? Basically, when you have an RCC, as I mentioned, it's usually of tubular, trabecular, glomerular tissue, or tissue from the collecting duct that has undergone neoplastic change and kind of gone rogue, right? This is kind of a worse version of that. Instead of having cells that are tubular but with neoplastic changes, you now have tissue that is differentiated into other connective tissue types, and this has a really, really bad prognosis. It usually presents with firm fibrous areas, and remember, it's fibrous tissue because it's connective tissue. And typically, they don't really have widespread hemorrhage or necrosis because it's not very vascular. There's also rhabdoid differentiation, which follows a very similar concept, but doesn't have a worse prognosis than RCCs. But sarcomatoid does have a worse prognosis. So as you can see, if you have an RCC without sarcomatoid differentiation, your 10-year survival is about 76%, while it's 13% with sarcomatoid differentiation. So not great. In terms of grading and staging, we follow the T and M system of classification that we've touched base on with other lectures and other types of cancers. So T refers, so going back to basics, so T refers to the tumor, N refers to nodes or lymph nodes, and M refers to metastatic spread. T can be from T0 to T4. T0 is no tumor, and that's probably not going to be a grade. T1 is when it's confined to the kidney and less than 7 centimeters in diameter. T2 is, again, confined to the kidney, doesn't extend into any of the surrounding structures, and it's greater than 7 centimeters. T3 is when it extends into the major veins or perinephric tissue, but not the adrenal gland or beyond the Gerota fascia. Now, the Gerota fascia is a really important layer. So you have, if you look at this diagram, you have kind of renal tissue here. You then have the renal capsule. You have the perinephric, peri meaning adjacent to, nephric meaning kidney, fat is fat. So you have the fat that surrounds the kidney, and above that you have the Gerota fascia. Now the Gerota fascia is a really important kind of wall that prevents that metastatic spread. If you have invasion beyond the Gerota fascia, that's usually a relatively bad indicator for prognosis, and that would constitute a T4 tumor. In terms of nodes or lymph nodes affected, so if you have no lymph nodes affected, that's N0. Regional lymph nodes is N1, and that's all you have. So it's either 0 or 1. And again, with metastasis, it's either 0 or 1. So no Mets is M0, M1 is distal Mets. That was RCCs. Now let's talk about some other tumors. So we have nephroblastomas or Wilms tumors, which are a rare tumor that occurs mostly in kids. It's the most common primary tumor in children. So children don't get RCCs, they get nephroblastomas. It typically presents between the ages of 1 and 4. And the interesting thing about nephroblastomas is that they, at diagnosis, most of them have mets to the lung, right? But the prognosis, usually with aggressive therapy, corresponds to a 5-year survival of usually above 80%. And that's incredible for a tumor that's presenting with lung mets, as you can imagine. For macroscopic features, it's usually a large, well-circumscribed mass. And as you can see, it's circumscribed and has a clear boundary. And 10% of them present with bilateral lesions. Microscopically, you see small blue cells with scant cytoplasm. And what you can see, and that kind of fits in with our macroscopic features of a circumscribed tumor, is that we see attempts of the normal tissue to try and cover up the tumor. And that's to prevent further spread. Moving on, we have angiomyolipomas, or AML, not to be confused with acute myeloid leukemia. That's also AML, but that's a different thing. So angiomyolipoma is a mesenchymal tumor. Mesenchyme is the embryonic tissue that gives rise to muscles, fats, blood vessels, and so on. And as the name suggests, angio, meaning blood vessel, myo, meaning muscle, lipo, meaning fat, oma, meaning tumor. So it's a tumor that contains blood vessels, smooth muscle, and fat. And that's all there is to it. Most cases are sporadic, but a very, very important association you need to know is that with tuberous sclerosis. Now, we touch base on tuberous sclerosis later in the lecture, but 20% of all AMLs, again, angiomyolipomas, not acute myeloid leukemias, are associated with tuberous sclerosis. And most patients with tuberous sclerosis develop AML. Does that make sense? So you have a whole bunch of angiomyolipomas happening. 20% of those cases also have tuberous sclerosis, but most patients with tuberous sclerosis have an AML. Kind of draw your Venn diagram, kind of makes sense. Vast majority of them are benign and can be surgically excised with a relatively good prognosis. Macroscopic features usually tend to be unilateral. However, if it's associated with tuberous sclerosis, they can be multiple and bilateral, as you can imagine. Hemorrhage is common because it's highly vascularized, because one of the components of the tumor is angio, or blood vessels. And necrosis is rare. Microscopically, you see a mix of all the three cell types that we talked about. And I've heard of this quite a few times, but again, I don't think it's super high yield. The smooth muscles tend to spin off from the blood vessels in a cartwheel arrangement. So they surround the smooth muscles surround the blood vessels, and that arrangement is typically called a cartwheel arrangement. Next, we have urothelial carcinomas. Now, before I move on, with most RCCs, talking a bit about treatment, it's not really super relevant to your level, but as you can imagine, our treatment would highly depend on our T and M staging. For tumors that are T3 or less, a nephrectomy or a removal of the kidney and some of the surrounding perinephric tissue is usually adequate. If there is spread, it's often a nephrectomy followed by additional chemotherapy or radiotherapy, depending on what's involved. I hope that makes sense. And that's a very stock standard approach to a cancer. Okay, now talking about urothelial carcinoma. So when I say urothelial carcinomas, these are carcinomas affecting either the bladder or the urethra. They're more common in male and tend to arise in older age groups. Again, very important risk factors you should know. Smoking is a huge risk factor. From an occupational health perspective, and you will learn this, and this comes up on exams, is aryl and aniline dyes are associated with cancers of the bladder and the ureters. And then radiation, going back to our RCCs, same principle. Often we treat something else in the abdomen, and as a byproduct can end up with urothelial carcinomas. They often present with painless hematuria, and I've actually seen in my GP placement 2 or 3 patients who, funnily enough, not funnily enough, it's not funny, who on the younger side of the spectrum, at about 30, 35 years old, and all of them presented with hematuria that was painless. After this, they underwent a cystoscopy, where you use a camera to look and inspect the bladder wall, as well as some imaging, and all of them were found to have bladder cancer, effectively, that was treated with a biopsy because it was circumscribed and limited to the bladder with no signs of metastatic spread, and that was good. Often, if the cancer, so if you have a cancer of the ureter, that very commonly can also present with bladder tumors. So always look out for that. So never look at the bladder without looking at the ureters. And then if you have a cancer of the urethra, of the ureter, resection is key. And with that, you would also usually resect the kidney, because they often arise near the renal pelvises, and that is obviously very complicated. So instead of trying to surgically amend the other ureter, you just take out the entire kidney and its corresponding ureter. If there has been spread, the prognosis is relatively poor, and the 5-year survival is about 10%. One common complication we really worry about is obstructive symptoms. So if you have a cancer that's invading or compressing on the ureter, that's going to block the flow of urine and cause reflux of the urine. That would lead to hydronephrosis, flank pain, and even post-renal AKIs. That's important to know. Now moving on to some genetic conditions. So firstly, we have von Hippel-Lindau syndrome, or disease. It's an autosomal dominant disease due to mutations in the von Hippel-Lindau gene. Relatively straightforward, right? We talked about how the VHL gene is quite commonly affected in RCCs, and therefore this disease typically presents with renal cysts and cancers, particularly clear cell carcinomas, and that's the particular association of RCCs with the VHL gene. That's mostly clear cell carcinomas. They usually present at a younger age. So we talked about how RCCs typically are in older patients, usually above the age of 50. But with von Hippel-Lindau, because it's a genetic disease, you can have a much younger presentation with multiple and bilateral lesions. And metastatic RCC is the leading cause of death in these patients. We then have tuberous sclerosis. Now, tuberous sclerosis is an autosomal dominant disease again that is associated with tumors of many organs. So it's not just the kidneys. You have two genes affected. So as the name suggests, it's tuberous sclerosis complex 1 and 2. And the common tumors you see are often to do with connective tissue. And going back to our angiomyolipomas, they're going to be quite similar. So within the skin, they present with facial angiofibromas. As the name suggests, angiofibroma means it's composed of blood vessels and fibrous tissue. In CNS, we see astrocytomas. In the heart, you can see rhabdomyomas. And in renal patients, or from a renal perspective, you see angiomyolipomas. And up to 80% of patients with tuberous sclerosis have an angiomyolipoma. It's always something you look out for. Additionally, you can also have RCCs and oncocytomas. As I said, clear cell carcinomas, most common and worst prognosis RCC to have. And then the oncocytomas are the benign lesions that are often present with the central stellate scar in 1/3 of patients. Next, we have birdhog dupe syndrome. Now, again, this is also an autosomal dominant disease because of a mutation in, as you guessed it, the birdhog dupe gene. And it's associated with multiple renal cell cancers, benign skin follicle tumors, and pulmonary cysts. The skin lesions are often picked up first because that's the first thing you would see. And the tumors can be a wide range of tumors. So you can have oncocytomas, which we know are benign. We can have chromophobe RCCs, which we know are the rarest form of an RCC, but have an excellent prognosis. And you can have other RCCs as well. So the way to treat these would be to follow them up with surgical resection of the renal masses. So again, benign skin follicle tumors, not a worry. Pulmonary cysts, unless they're large or hemorrhaging, not a worry. But the RCCs, worry. So we want to surgically resect them and follow them up. And because it's autosomal dominant with a lot of these conditions, we would screen or follow up their first-degree relatives as well. And that's all we had for cancers of the renal tract and some genetic conditions affecting the kidneys. I hope that all made sense. As always, if you have any questions, please feel free to get in touch. I know that was a bit on the niche side of things. And as always, please look after yourself and please look after your loved ones.